If you're just joining us, you are at the Accords Learning Health Systems Seminar Series for a panel discussion today. We'll give people one more minute to join and then we'll get started. All right, well, let's go ahead and get started. Thank you for coming, everyone. My name is Bethany Kwan. I'm the Director of Education for Accords, which is the Adult and Child Center for Outcomes Research and Delivery Science. We just recently received a center designation on campus, which we're very excited about. If you're not familiar with Accords, we are a research institute at the Inpatient campus where we focus on pragmatic research in real-world settings to improve healthcare and outcomes, providing a multidisciplinary collaborative research environment, strong methodological cores and programs, including our education program here that's represented here today. We do consultations and team building for grant proposals. We provide mentorship, training, and support for junior faculty. And as I mentioned, we have extensive educational offerings, both locally and nationally. Next slide, please. We have a number of upcoming Accords education events. Next week, our Qualitative and Mixed Methods Research mini-series is presented by Dr. Karen Albright on rapid qualitative analysis. Then next month, this Learning Health Systems Seminar Series continues or concludes actually with a global health model of learning health systems based on the Swiss experience, presented by Dr. Stefan Bose. And then in May, we have our final Qualitative and Mixed Methods mini-series, which is presented by Dr. Allison Tong on dissemination of qualitative research. Looking forward to all of these. And then most exciting is our CopperCon, our Colorado Pragmatic Research and Health Conference, which is our third annual conference, May 23rd, 24th, and 25th. It is a hybrid conference. You can attend virtually or in person on campus, or a little bit of both, whichever you prefer, and registration is open. If you are an employee of the Anschutz Medical Campus or a member of the Colorado Clinical and Translational Sciences Institute, which includes all of our colleagues at Denver Health who are attending today, then registration is free. So we hope you register and attend CopperCon. Today's session is our Learning Health Systems Models and Methods for Embedded Research seminar series, focusing on local learning health systems models. And we have some fantastic speakers here today to tell us about the experience of Kaiser, Colorado, Denver Health, and the Nav Lab, which collaborates with the UC Health System. And our speakers are Dr. Michael Ho, Dr. John Steiner, and Dr. Laura Podewils. Dr. Podewils is the Associate Director of Learning Health Systems and Evaluation in the Office of Research at Denver Health. Her work at Denver Health has spanned from managing disease investigation and monitoring for communicable diseases for Denver residents, including COVID-19, to implementing and evaluating programs seeking to improve care and care linkage for persons who are justice involved, models of care for housing for persons experiencing homelessness, and examining racial and ethnic disparities in health outcomes. In her current role, Laura directs a team that provides support for conducting engaged, collaborative, and innovative research and evaluation to improve quality of care and advance equity. She also holds faculty appointments with the Colorado School of Public Health and Colorado State University. Dr. Ho is a staff cardiologist at the VA Eastern Colorado Healthcare System and professor in our School of Medicine. He leads the Nav Lab, which is a multidisciplinary team focused on working with clinical partners to conduct program evaluation and improving the value of care delivered to patients. And last but not least is Dr. John Steiner. He's a senior investigator at the Institute for Health Research at Kaiser, Colorado. After 20 years on faculty at the University of Colorado Anschutz campus, he served as the senior director of the IHR from 2008 to 2016. His research focuses on increasing access to care, health equity, social determinants of health, treatment and visit adherence, prevention and treatment of hypertension and diabetes, and importantly, promoting a learning health system. Our session here today will be moderated by Dr. Russ Glasgow, who's the director of our Dissemination and Implementation Science program here in Accords. Thank you, and I'll turn it over to Dr. Glasgow.
Thanks, Bethany. Just want to say this is exciting for me. After hearing a lot of examples in this series, those of you that have been with us, of other national programs and things, we're excited to kind of bring this together and hear some of our what's going on here locally. So I think this will be great. We have three great speakers, and my job here is to move us along. So I'm anticipating we'll have a lot of questions and you really want to hear from them. So I'm going to kind of be timekeeper and move us along. What we're going to do is to start, we'll ask each of Laura, Mike, and John, and we're going to go in that order, just to give us a brief background on their program. So you have an idea of at least the big picture issues. And then I have a couple of questions I just like to start off to make sure that we cover based on prior sessions that we've had. And then it will be open. And as I put in the chat, please do use chat very liberally. Both Bethany and myself will be monitoring those, and we will integrate those questions as we go. So I'm really looking forward to it. And with no further ado, Laura, I think you're going to share your screen and start us off.
Hey, good afternoon. I'm really excited to be here as part of this panel and provide a really quick overview of our learning health system at Denver Health. As most of you are aware, Denver Health is an academic urban safety net institution. We provide care to approximately 1/3 of Denver's population, and that's through 950,000 individual encounters every year. In 2017, we established our Office of Research to provide the administrative, operational, and scientific infrastructure to both promote and support research, quality improvement, and program evaluation across our institution. Over the past 5 years, we've really been focusing on our role as a learning health system. And what that means is generating quality data and then conducting research, rigorous quality improvement, and evaluation, and then using those lessons learned to disseminate and publish and present to our external partners in the research community and with other health systems, and then when appropriate, translating that information and evidence into our practices. As with any other learning health system, there are some strengths and some weaknesses, and I'm going to highlight some of our strengths. As a safety net institution, we have an incredibly diverse patient population. We have over 280 different ethnic backgrounds represented by our patients. Denver Health is a level 1 trauma hospital, and we have community clinics throughout the Denver area, as well as school-based health clinics and providing care in our Denver city and county jails. We are fully integrated with Epic electronic medical records, and over the past few years, we've spent time with our community partners to improve the exchange of data and also integrate data into our electronic health record. And that includes exchange with Colorado Coalition for the Homeless and the CDPHE mortality data. In 2020, we committed to being an anchor institution. And that means that we hire locally, we source locally, and we are committed to uplifting both the economic and social needs of our community beyond traditional healthcare. We also really value the voice of our community and of our patients and have several community engagement committees. We have one in the Office of Research. We have a community engagement committee in our board that is represented by over 50% members from our community, and a patient and family advisory council. Like the university, we rely on COMERB for review of human subjects research protocols. But we recognized that as a learning health system, we really needed a pathway for dissemination and publication of our quality improvement and evaluation efforts. And so we created our own internal quality improvement review committee, and this is endorsed by COMERB. We also have a pilot grant funding program that provides seed money to junior investigators and staff across our institution, aiming to improve our healthcare delivery as well as health equity, and that others can learn from. We are one of 11 national learning health systems recognized by the Agency for Healthcare Research and Quality. We participate in a panel that identifies key areas of interest for evidence-based syntheses. And then finally, we were one of the first healthcare institutions in the nation to adopt the lean continuous improvement processes and toolkits, which has really provided a foundation of continuous improvement at every level of Denver Health. So where are we and where are we going? We're going to continue to support independent clinical research, program evaluation, and QI across our institution. We are working with 2 executive sponsors to take evidence learned through several research efforts over the last few years that is focused on the healthcare and the health of persons with housing instability who are unhoused. And we're now trying to figure out how to integrate that into our healthcare delivery system. We are evaluating key organizational initiatives, including our 3-year equity blueprint, pipeline programs that are aiming to bring our entry-level staff and our patients into our clinical workforce. And we're also expanding our assessment and resource linkage for health-related social needs or social determinants of health. We will be evaluating both the implementation and the impact of those efforts. As we go forward, we hope to expand our capacity for community-based participatory research and stakeholder engagement in our practice, our research, our evaluation, and our QI projects. We will continue our work with AHRQ, and we're also looking to refine the approach in which we prioritize areas of evidence to integrate into our healthcare delivery system, because we have limited resources, and doing so really requires involvement from every level of our organization, from leadership to IT to our clinical staff. Thank you.
Thank you, Laura. That was great. And I'm sure we'll have a lot to follow up on. I know I'm personally intrigued with the work you're doing around the social needs there. And maybe if we have a chance to hear a little bit about your experience with the ARC, with the other learning health systems too. But we'll see. And with that, Mike, you're up if you want to share your screen.
Great. Thanks, Russ. So it's great to be on this panel, and thanks for the invitation. So I'm going to talk briefly about the Nav Lab. This was a multidisciplinary group that came about maybe about 3 or 4 years ago, and it was funded as part of a School of Medicine initiative under one of the Dean's transformational grants. And so we started about 3 or 4 years ago, and our main goal really is working with UC Health and UC Hospital to operationalize a learning health system in terms of doing program evaluation, as well as trying to apply those lessons learned to change care for patients. And so as part of the process, I mean, I would say, unlike Denver Health and Kaiser, where the evaluation program is funded as part of the health system, our funding comes from the School of Medicine. And so we've worked with both UC Health and the School of Medicine in terms of the different divisions and clinical departments for our different projects. And I would say we have more of a decentralized process where we will, talk with different partners and, see if we can do specific projects based on those partnerships. And a lot of it will depend on whether the projects are feasible after some initial discussions in terms of feasibility. And rather than kind of give a broad overview, I thought we'd talk about a couple projects just to highlight, things that we've done as part of a learning health system. And so the first project that I wanted to kind of highlight is a project called the Inpatient Nurse Staffing. And the problem here that we were trying to address is, how to staff appropriately, right? Because I think if you in any inpatient ward, you can overstaff where you have a lot of nurses and not a lot of patients. And so the cost of that could be a lot because you have a lot of nurses that aren't working at their full capacity, or if you understaff where you have a lot of patients but not enough nurses to help with patient care. And so this was a project that we worked with Michelle Feller, who's the UC Hospital Director of Nursing Resource, where we were trying to use predictive analytics to predict the number of staff absences so that then she could create a pool of on-call nurses to help staff units going forward. And so this, the goal of this model was to predict, kind of for the next week or the next 14 days, how many absences that she could expect, so that then she can plan for her staffing needs better. And so I won't go into a lot of the details, but this is an example of using data that's available in the EHR or through other electronic sources that can be used to kind of to improve care. And then the second project I'll just quickly highlight that the Nav Lab has been working on is really, a function of, we did some evaluation of how UC Health was doing in regards to transfusion practices. And we found that there was a number of transfusions that were done that may not have been consistent with guideline indications. And so working with a lot of executive sponsors, we were now conducting a clinical trial where we're randomizing providers to one of 3 ordering menus to compare which ordering template will lead to more guideline concordant care. And so this is just one example within a learning health system where we can take data to understand how we're doing. And if there's areas where we need to improve care, we can then do rapid randomized controlled trials to try to improve care, because in a lot of these situations, there may be equipoise in terms of what's the best strategy to improve care. And so I think, as probably alluded to in prior talks, I mean, within a learning health system, I think we want to understand what we're doing, but then take the next step towards trying to improve that care. And so this clinical trial is ongoing, and hopefully we'll be able to present the results in the next 6 to 12 months. And so I think with that, I'm happy to share more details about each of these projects, but I think it hopefully brings some more specifics as to kind of the breadth of what we can try to do within a learning health system. And maybe I'll stop there and turn it over to John.
Perfect. Thank you so much, Mike. And I love the examples. That really helps. Maybe one of the things we can return to discussion is about doing the rapid trials, how we make that really rapid. But it was also great that you started talking about some of the differences between these learning health systems too. So John is up next. John, I think you might be frozen. At least I'm not seeing or hearing you. Looks like bad timing.
Well, good morning, everyone. It's fun to see all of you, many friends from many pathways over the years and decades here this morning, as well as a bunch of people who I don't know. In the next few minutes, I just want to give a quick overview of the learning health system as it currently exists in Kaiser Permanente here in Colorado. The next slide, please, Jordan. I would start by saying that I think in many respects, Kaiser is ideally set up to function as a learning healthcare system. there are many of our organizational assets that really help us in this role. And I've listed a few of them in this slide. The first is the presence of an embedded research department of researchers, full-time researchers who are employed by Kaiser. The investigators who work here, many of them are attracted by the fact that in addition to doing extramurally funded work, they can also do work that has a direct impact on the care delivered to Kaiser members. And we maintain a mix of internal and extramural funding so that we can speak both to the scientific community as well as to the local organization. As you probably know, we have a denominated population of over 500,000 adults and children who receive Kaiser Permanente insurance. Since we know who gets insurance from Kaiser, we have access to one very critical feature, which is that we can identify both the people who use care in the system as well as the people who, for one reason or another, do not use care in the system. Kaiser clinicians exclusively serve this population, so we can track their behavior, their prescribing, their image ordering, their referral practices, and so forth, and use those in studies of clinician behavior change, which I'm happy to talk about some examples in a bit. And finally, we have a comprehensive research data warehouse with over 15 years of data, so that we can draw on that for most of the data that we use in research and evaluation work without having to build data sets from scratch for each individual effort, each individual study or program project. Next slide. At present, some, but by no means all, of our learning health system activities are focused within what we call the IMPROVE program, which stands for Innovative Methods Promoting Regional Operational Value and Efficiency. We've had a sort of a semi-formal learning health system component within the Institute for Health Research since about 2015. And in fact, most of our investigators have ongoing projects with the delivery system in addition to their extramural work. These projects tackle a broad array of topics, and many of them are what I would call hard problems in the sense that they cross traditional departmental or system level boundaries that many different reporting lines in the organization have input into the way that we communicate with our members, as one example. And from this learning health system perspective, we're able to see that broader vantage and to look at the multiple stakeholders and the multiple inputs into these tough questions. The IMPROVE program provides some core funding for myself and our project manager, Shane Mueller, who's on the call with me today. It's helped us refine a prioritization project by which we handle new requests for assistance with learning health system initiatives. It also provides a limited amount of funding for projects that we approve, although we're always looking to leverage the seed money that the IMPROVE program can provide with other internal resources or find overlaps with extramurally funded grants that our investigators are conducting. And with these funds, we're able to maintain a portfolio of about 10 projects at any one time. The typical project designs range from secondary data analyses, such as development and implementation of prediction rules, to intervention trials. Again, these are all pragmatic trials along that kind of spectrum of pragmatism that Russ and others have described, using randomization as well as other quasi-experimental and design and observational designs such as interrupted time series designs. We collect a limited amount of primary care data. We do rely heavily on qualitative and mixed method work to anchor a lot of our quantitative efforts as well. And the final slide. I'll close by perhaps transitioning us to some of the discussion and trying to identify some of the creative tensions that we've identified that I think are probably common to other learning health systems. The first one of these in organizations like all three of ours is what I call this dance between research and operations. And in moments of bitterness, I've characterized this as researchers saying, if you fund us, we'll show how valuable we can be to the system. Whereas the operational leaders are saying, if you show us how valuable you are to the system, then we can fund you. And getting past that impasse is, I think, one of the critical elements in really launching a learning health system. Another creative tension is choosing projects. There are some that you do to demonstrate your value that constitute quick wins. But those, as I said, are rarely the kind of hard problems that an institution really has to grapple with and learn about. So these harder problems are also the ones with a greater potential for impact. A third creative tension is how rigorously we do the work. Sometimes it's sufficient to kind of guide operational leaders in the right direction, and they need to make decisions rapidly and without oftentimes conclusive evidence. So we can sometimes rapidly muster evidence to help guide those decisions, even if those evaluations or those studies lack sufficient rigor to be publishable. But of course, all of us as researchers, publications are a key element of our own professional growth, and we're also looking for ways to ideally have it both ways, where we do research that's sufficiently rigorous to be publishable while still being timely enough to be useful. As you all know, our research designs, once put in place, are oftentimes inflexible, and this is a constant tension with an organization in which operational leadership priorities are constantly changing. And so the question of when we adapt an ongoing study to fit a new organizational context remains one that we grapple with. We certainly encourage the early and sustained involvement of operational clinical partners and where possible with our patients or our members. We've found almost invariably that getting all of these stakeholders involved in the front end produces better and more meaningful work than when we get retrospective requests to analyze some data set that somebody's sort of thrown together. And finally, the scale of the work is always a question. Should we start in a system like ours with 26 primary care clinics and pilot a new intervention in one of them? Or should we implement at scale? Or should we use variations on that? Like stepped wedge sort of designs where we sequentially implement. So these questions come up over and over again in these projects. And I think with that, now we can turn to the really interesting part, which will be the discussion. Russ, it's back in your hands.
Thanks, John. That's phenomenal. And fortunately, we do have an hour to address each of those wonderful bullet points that you discussed there, which I think would be great. I'm going to transition to the second phase of our conversation today in just a moment, but I want to call out something that Mike has set a great example of already, and that is please use chat. And the extent to which our presenters can multitask, please do use chat. I think that can help, enliven the conversation and maybe address some of the questions on chat rather than verbally. I'm going to start off with just a couple of structured questions that I'd like to ask each of the presenters to address, if they would, briefly, based on what we've heard in prior. So I'm guessing these will be questions a lot of you have based on prior discussions. And maybe for this first one, if we go, let's go in reverse order with John and then Mike and then Laura on this one. But the question's about stakeholder engagement. Who are your stakeholders? There's such a huge variety, all the way, from patients and families to various types of clinical staff to organizational decision makers, maybe community representatives. Not only who do you involve, but how do you engage them? Sometimes that is another tough dance, John, to figure out, all with the varying perspectives. So if we could just go and hear from each of you briefly, which stakeholders and how do you engage them?
Again, how long have you got? I think from the system perspective, Kaiser historically has had a clinician group and a health system group, and understanding the org charts and who has a stake in each question is really important. Because very often, as I said earlier, they do cross traditional departmental and disciplinary boundaries. So and oftentimes you don't know this at the beginning, and it's a matter of kind of exploring and finding out who needs to know at each level. I would say self-critically that we've done a less good job than we could have of involving our members as stakeholders. Although we're trying to change that. In one of our ongoing improve projects, for example, we're looking at our whole communication strategy, our outreach strategy to members to remind them of appointments and lab tests, and communicate messages about changes in COVID policy and that kind of stuff. And what we've done there is to use our data systems to identify members who might have an opinion on these, and then reach out to them qualitatively. And what a couple of our excellent staff are doing are taking sound clips from these qualitative interviews and putting them into the slides that we share with our organizational leaders to illustrate what we're learning. This has been, I think, profoundly effective at getting operational leaders to pay attention to what our projects are showing. I'll stop there.
Fantastic. Mike?
Yeah, I mean, I think it really depends on the question or the evaluation that we're doing in terms of who the stakeholders are. I mean, for us, the Nav Lab, ultimately, right, our stakeholder is our funder, who is the dean and the senior associate dean in the School of Medicine. But I think in terms of trying to make an impact with our projects, I think our stakeholder, we usually require that there's an executive sponsor for our project, whether that's someone at UC Hospital or someone who's in a leadership position within our division, academic divisions or departments. So someone that could then take the results and disseminate it more broadly or implement the findings from our evaluation. So but I think at the end of the day, it really depends on what the project is intended to do, because the stakeholders could be providers at the clinic level or at the unit level. And so sorry to be vague, but I think a lot of it depends on the project.
I always say to every important question, the answer is it depends, Mike. So well answered, I think there. So Laura, what about your involvement as stakeholders?
I'll go ahead and echo that it depends. I think, as a learning health system, that cuts across our entire organization. We're not a centralized unit. And so some of the projects, evaluations, QI, clinical research stems from a clinician or a staff member seeing a need for improvement. And whether that's grant funded, because we do have quite a bit of grant funding and external funding within our system, then it often derives from some of those stakeholders. I also think that we can do a much better job of involving all of the stakeholders, and whether that's our community or our patients, in the early stages of when we're planning to do something or helping to give input on the shape of our evaluation, I think has been really critical. And I know a lot of projects and efforts we do that, but I think more intentionally making sure, because the lasting impression will be dependent on those folks being invested from the beginning. And then as we do more, as I said, like organizational initiatives, I feel like a lot of our team's role has been connecting a bunch of dots. So there's so much great work happening across the organization, and recognizing that there's synergy and opportunities to collaborate across disciplines, learn from one another, and bring it together to both have it more robust for whatever it's intending to do, but also mapping it up to our strategic, organizational initiatives that are really being prioritized. So yeah, don't know if I answered it. It depends.
I think you each nailed it and hit different parts, but very impressed with some of the innovative things that each of you are doing too, rather than having one quote stakeholder panel, that you just use for everything. That was super. Some of your comments, Laura, bring up the next thing I'd like to talk about, and that's issues related to health equity, and maybe in particular, social needs or social determinants of health, how those issues are integrated, if they are, into your learning health system. Prior discussions, we've had a lot of questions about, it seems like this is a great opportunity, to really get out there with the learning health system to address health equity, and at the same time, we've all seen publications, particularly things around the EHR and stuff, that you may inadvertently be exacerbating health inequities, rather than addressing them. So I wonder if you could each just say, a word about how you're addressing health equity, kind of spinning off the last question. And if I have it right, I think completing my Latin square design, if we could go in the order of Mike, John, and then Laura.
Yeah, and I can be brief. I think it's an important issue in terms of trying to understand disparities. I think, looking at our Nav Lab project portfolio, I don't think we've, addressed that at all in our current work, but I think it's something that we would definitely be interested in pursuing.
Okay, John?
Identifying social risk factors in clinical settings has been a big organizational initiative in Kaiser over the last 6 or 7 years. I've been involved with that both at the national Kaiser program level and locally in Colorado. So a lot of the effort to develop a standardized screening process for social risk factors, as well as to develop a system to refer Kaiser members with social needs to the community organizations that generally can most effectively address those. There's a ton of work going on across the organization. I'll just mention 2 or 3 things that we've focused on here in Colorado, just to give you a flavor, since I haven't given any really specific examples of how this has played out here in our area. For a decade or so, we've been providing a standardized survey to our elderly Medicare Advantage members that is asked about issues of food insecurity and loneliness, to emphasize 2. And in a couple of large observational studies, we've shown that elderly diabetics in Kaiser, Colorado, with food insecurity have worse indices of worse hemoglobin A1C levels, as well as higher utilization of care. And in a study that we're actually revising and resubmitting currently, we've shown that changes in loneliness between surveys in older adults are associated with changes in depression and anxiety, so that these social needs really do translate into demonstrable changes in clinical outcomes that matter to patients, members, and our clinicians. We're also in the final phases of analyzing a large randomized trial that was funded by Kaiser to look at the duration of medically tailored meals after hospital discharge for Kaiser members in this area. With our partner is Project Angel Heart, as many of you know, a community organization that delivers medically tailored meals. So we randomized 650 Kaiser members who were being discharged from the hospital to receive either 2 or 4 weeks of medically tailored meals and see if that affected issues such as mental health, food security, social isolation, and of course, utilization of care. And the results aren't final, so I'll just create that as a teaser, but it's more to show what the capacity of the system is to do randomized trials that address social risk.
Thanks, John. If I could just do a brief follow-up before we turn to Laura there. I'm probably going to get this wrong, but my understanding is you're bringing up this issue about the national collaboration and the infrastructure you have there. And I believe there's a standard set of questions now used across the Kaiser systems for social needs and some kind of a dashboard. Is that anywhere close to correct?
It's pretty close to correct. Yeah, it's not universally used, but what we're trying to do is to use the social risk factor tools that Epic has developed, and actually, as an early Epic customer, we're trying to persuade Epic to change some of the questions they've asked. But really, what we're promoting is the use of the Epic social needs wheel to try to do more widespread screening, even in a privately insured population like Kaiser, as we've shown in this work and in at least one large national survey. The prevalence of social risk factors is surprisingly high.
Yep. Great, thank you. And Laura, I think you're a great one to finish up, given certainly Denver's health position in terms of addressing health equity issues. But if you could just give us, some examples or thoughts of the way that you're addressing these issues.
Sure. So I think there's a number of things. And one, we've recently rolled out an initiative across Denver Health to improve the way in which and the quality of which we collect information on race, ethnicity, and language. It's called the REAL Project. And we've really spent a lot of time transcreating the way in which those questions are asked, because some of those are social constructs that don't resonate with folks. And so that's allowing us an opportunity to improve the quality of our data and identify our communities within our communities within our communities and look at healthcare. And then touching on the social determinants of health, we have been using the Accountable Communities HRSN tool in our well child clinics, and we're evaluating the implementation of that. And we're in the process of rolling it out much more broadly for some key populations, our higher risk Medicaid populations, and have adopted that Epic wheel that allows you to kind of highlight things in real time at a clinical encounter about people's needs. And we're currently in the process of figuring out how we can link them effectively to resources and using some software called Aunt Bertha to be able to leverage that. Mm-hmm. We also have existing partnerships with Hunger Free Colorado that does, kind of follow up. And so continuing to explore that. And then I mentioned some of our work in the sort of housing space. We are part of a randomized trial that's actually going to be able to provide permanent supportive housing to 150 people in our system, led by Dr. Sarah Stella in our group. And we're also identifying beds for respite care. So like kind of a step down from our hospital for those persons experiencing housing instability. So a lot going on in this space. And I think there's been suggestions in the chat that we should all work together. And I think that this might be actually an area for us to come together. Thanks.
Great. No, thank you. So much wisdom involved in each of those answers. That's great. And actually, Laura, you anticipated where I was going to go, trying to follow chat. And please keep those questions and comments coming in chat. But I wonder if it sounds like from chat so far, there's not been a a great number anyway of the three of your organizations working together on learning health systems to date. But I wonder if you could just talk a little bit more. John has mentioned some of the national Kaiser collaborations, with that network there. But I'm wondering particularly if either Denver Health or Mike with your Nav Labs, if you've done projects with other organizations, and if you see, or kind of, I guess, the pros and cons of those sort of collaborations as well in terms of learnings.
Sure, I'll go ahead and
Yeah,
start.
sure.
We're involved with a number of different consortia and collaborations nationally, including our tuberculosis work. We're part of a large newly awarded a randomized trial that's going to be looking at post-COVID infection. And so we're part of that. We're part of an HIV network across the nation. We have a vaccine safety data effort that is part of also a national effort. So we definitely do collaborate with other health systems in many different spaces, whether it be research projects or collaboratives in that way.
Great. If I could do just one quick follow-up. I know a number of us are interested, and we're failed applicants for the ARC Learning Health System initiative there too. So I wonder if you could just reflect a little bit on how that national partnership has gone, and whatever you'd like to share, the good, the bad, and the ugly about that type of national partnership.
Sure. So our research director, Romana Hasnain-Winia, has actually been at the forefront of a lot of that work and has contributed to the ideas behind some of those evidence-based syntheses. Ones that have been conducted and completed include screening for childhood depression, reducing length of stay in the hospital. And just recently, she suggested the idea of looking at quality improvement as a mechanism to reduce health disparities. So those are ongoing, and I'm happy to share some of the links to those that have been conducted in the chat, if that's helpful.
That'd be fantastic. And also, if you're able to on the spot, I've just been really intrigued and impressed with some of the things done with Aunt Bertha that you mentioned earlier. If you have a chance to add anything about that in the chat, that would also be great. So Mike, any thoughts or experiences about collaborations with other opportunities with other learning health systems?
Yeah, I would say, for the Nav Lab, we haven't collaborated to date with other learning health systems. And certainly, it's really in its infancy as a group. And I think over time, we would like to collaborate with other health systems. I think our early years, we've been trying to gain traction within UC Health, and that's been our focus so far.
Mm-hmm. Understandable. John, you gave us several examples of other Kaiser partnerships. Anything you'd like to add to this notion about learnings with other learning health systems?
Well, it's sort of a cautionary note, I guess. I mean, who can dislike collaboration on the one hand? It sounds terrific, but having worked at in the university system, partnered over 30 years with Denver Health, and having spent my last 13 years in Kaiser, they are all complex ecosystems, there are times when learnings are sufficiently generalizable across systems, but there are times when context is critical, and something that might work well at one of those institutions has no chance at another institution. It's even a problem within individual clinics within each of our healthcare systems, I suspect. I mean, it can't be just a Kaiser joke to say, you've seen one Kaiser Medicare office building, you've seen one Kaiser medical office building, even at the very micro level. These sites have their own culture, and things that might work well require adaptation to other settings. So I think and I'll say something provocative, just to say, I think that collaborating in conventional research between our institutions is actually going to be far easier than collaborating in learning health system research. And shoot me down. I'd love to debate that point because I'm not sure I'm right, but I just said it.
Let's let's see if any others do. Thank you. I was hoping we could count on you for that. And thanks for sharing the voice of experience there about things too. And of course, makes my tail wag to hear your comments about the systems perspective and the context and how critical that is. Laura or Mike, any thoughts about John's provocative statement there?
No, I really enjoyed listening to that, because I do think a lot of it is dependent on context and your sponsor, right? I mean, I think particularly with Nav Lab projects, we've seen sponsors come and go, and the enthusiasm for project really comes and goes with the the sponsor. And so I would say I think it's important to learn from others, but whether those learnings can be adopted will depend on the enthusiasm of your sponsor or who you're getting to sponsor the project at your institution. Mm-hmm. And the ultimate success, I think, depends on that.
Laura?
Well, I'm not sure that I agree or that I strongly disagree, frankly. I think that kind of like in the whole spirit of a learning health system, that we want to share our lessons learned so that they could be adapted and adopted to other systems. And that there is likely value of taking on something and then recognizing what works well in environment A and in B, because even within Denver Health, there are so many little micro environments that maybe it's what worked at Kaiser, which might work in some subset of our organization. So I think that it would probably be really powerful if we did work together and we could figure out how to take some evidence, like real world, try it out and really learn and then share that more broadly. So.
Great. I'm going to do something a little unusual here for a moderator, but I'm just wondering if any of you have a question for the others or other issue you'd like to bring up from what you've heard about the learning health system and maybe how it might be similar or different from each other. Is there any cross talk or issues any of you'd like to bring up? Not hearing any right away. Give you be another couple minutes to do that. One other question we've gotten quite a bit is, given the plethora of things that could be focused on, the number of important, clinical community issues, problems there are there to address, how do you select which projects that you take on? Is there a screening process? Who brings those forward? How are they vetted? We'll have to be quick here. Time's coming, but let's hear each of you. Maybe John, you want to start?
Well, first acknowledging this is a problem. And what we're now doing is that we have a not arduous, but a standardized intake process. And we vet these requests. If sometimes I have the authority to say, not so much, or this is a much bigger project than you realize, or the answer to this is already known, or something like that. But for projects that make the cut, we have both an IHR level review with our executive director and a team of other people. And ultimately, we bring all these to two of our vice presidents in the medical group and health plan who help us make prioritization decisions. Like all budgets, our budget is limited, and so we need to make hard choices. And frankly, having executive level backing helps us say no at times when it's painful to do so.
Okay, very quickly, Laura, and then Mike.
Sure. So we are not centralizing the approval or the disapproval of people's efforts. I think that one of the key things that we are aiming to do across Denver Health is allow everyone at Denver Health to connect with being part of the learning health system. So quality improvement projects are happening at every level, evaluation and research. People are constantly applying for grants. They often come to us for consultation to improve the scientific rigor of that. And in terms of what our team takes on, we are also partially grant funded, not completely operational. We have a very small operational team that's small and mighty. But we're really trying to think about what are those overarching strategic organizational initiatives, and then really linking people together to make things stronger and more robust.
Okay, super. I've not been quite as great a steward of time as I had hoped, but I do want to close by giving each of you an opportunity, probably about 30 seconds, just if there are any kind of closing thoughts or tips, one thing you'd like to leave the audience with here when they're thinking about their own issues in learning health systems. And Mike, why don't we let you go first on that one?
Yeah, I guess I would say, finding a good executive partner and sponsor is, I think, one of the keys to operationalizing a learning health system and ensuring that your findings are applied to improve care. Perfect.
Laura?
I think leadership and vision is really paramount. But also recognizing that, again, everyone is probably already doing a piece of this, and allowing to figure out how they're already doing it and how they can feel connected to that effort.
Super. And then John, we'll let you have next to last word, because I need to turn it back to Bethany then to close up.
Well, I'll speak more personally, I guess. In a 35-year research career, this has been some of the work that I've found most meaningful, most important. The kind of stuff I want to tell my grandkids about. The potential for really making a difference in learning health system work is extraordinary.
Thank you. Bethany, back to you.
All right. Well, thank you so much to our panelists today. This was fantastic. And it was interesting. People have been asking for local examples of learning health systems. And I just don't think that we could have had any better representation. So I really appreciate everyone coming to talk today. Thank you, Russ, for your fantastic moderation. And thank you, everyone, for your attendance here today. We hope you complete the evaluation. It really does help us inform our future educational events, a learning education system, I guess. And I hope you all join us for future educational offerings, and that you register for CopperCon. That's coming up next month. I have to work that in there. Thank you all, and we'll see you next time.
Thanks much.
Great, thanks.
Thanks, everybody. It was fun.